Good day to everyone who's joined us here. I believe it's Happy World Contraceptive Day, Contraception Day. I am so pleased to welcome you here today on behalf of Sexual and Reproductive Health Matters, the journal, an organization that is so pleased to partner with the Pleasure Project and WHO on bringing out this very important systematic review that we are so pleased to publish. And I'm just here to really welcome you all and to thank you to the Pleasure Project and WHO for bringing out this piece of evidence. I don't think my screen is sharing, but I want to draw everyone's attention to that this systematic review that is coming out is actually the culmination of a series of articles that we have, here it is, that we've put together in SRHM in partnership with Anne at the Pleasure Project and Agents of Ishq with Paramita Vora. And really, I think I just would like to call your attention to everyone watching right now is that this series of papers that we brought out over the years and collected shows us a couple of things about SRHR that are a stark reminder. One is that there are many questions we forget to ask, some of them about pleasure, but also about how do we even begin to talk about pleasure. And what we hope that we can draw you all to as an audience is to remember that one, the language of danger, the language, the sanitized, medicalized language that we tend to talk about contraception is missing the point that we're talking about people. We're talking about people's lives. And I do draw you and encourage you to come to the website and take a look at all the different ways that people have indeed asked about pleasure and asked these questions. And importantly, in the many forms of evidence that we know matter to influence action. So through quantitative, qualitative studies, but also through poetry and through podcasts and to hearing from people's voices and lived experiences. And I want to draw you to one specific thing that really struck me. And when I think about this review that we'll be talking about in tonight's event is that we often talk about a call to action when we bring out evidence, particularly in public health journals. And Anne and Paramita called to us for love letters and said, tell us your stories. Tell us about the ways we've talked about pleasure. Tell us your stories about not just the studies you've done, but your own life experiences. And as a journal for us, for SRHM, what's so important is that we remember that many forms of evidence bring us to action and bring us to ask the questions that others don't. So I'd like to just really congratulate and thank you all for being here and for putting together this really important piece of evidence that will certainly push the needle on what we understand around pleasure, around evidence, around forms of evidence, and really is a call to go much further in terms of thinking about pleasure and people's lives and certainly action. And at that, Anne, I turn to you and thank you so much.
Thank you very much, Sapna. And it's really, really exciting to be able to start this webinar and to share with you all the culmination of a lot of work. I'm Anne Philpott. I'm a founder and co-director of the Pleasure Project, and also to do this on World Contraception Day. So happy and pleasurable World Contraception Day. I just wanted to do a little bit of an introduction before we really get going. The Pleasure Project has for over 20 years been highlighting the elephant in the room in the public health world, that people have sex and a key reason for having sex is pleasure. Yet the sexual health world has almost magnificently managed to avoid this inconvenient truth and has rather over-medicalized interventions, and today is really about discussing changing this. And I often compare this to the way that we might encourage people to use toothpaste or to brush their teeth, and we would probably highlight all the advantages of that, like their fresh mouth, their beautiful sexy smile, and we wouldn't over focus on all the negative sides of not brushing their teeth. And but that's what's happened in the world of sexual health. We've overemphasized all the negative effects, the death, danger, and disease, rather than what could be the positive effects of being able to practice good, safe sex. And this has happened to a more extreme degree in contraception promotion, which has also showed a very gendered bias in terms of underemphasizing the importance of pleasure or sexual well-being for users of contraception. And I think that that contrast is really, really stark. And you may have seen it in the news recently that male contraception research has moved to a next stage, and yet the research into male contraception has always halted and stopped if there's been any effect on pleasure or even a side effect, whereas the history of many decades of contraception provision has assumed and required that users will put up with significant amounts of side effects. So this research that we're launching today comes at a really critical moment, and it's really groundbreaking and unique. It's really about asset framing away from death, danger, and disease in order to be more effective. It's also about this critical moment in global public health, about the importance of being innovative, creative, and really changing the conversation away from the historical narratives that have only focused on fertility control. And it's also critically about cost effectiveness and how changing a conversation can be really good value for money. But it's really at essence about motivations and about treating contraception users as complete humans. But the work we've always done at the Pleasure Project has always had a strong evidence base to it. And we're therefore delighted to work with WHO and HRP on this and all the other partners who will speak today. And so today, we will hear about this exciting research, which has published today about the extent to which sex life concerns have an effect on whether contraceptive users stop or change their method. And remarkably and shockingly, this is the first time this question has been asked in a systematic review of the evidence. And yet we knew from our first systematic review, which we can put the links to these in the chat, that pleasure integration into sexual health interventions lead to more safer sex and significantly more condom use. And we really wanted to know whether this was also important for contraception use. And we'll be able to share the results with you for the first time today, which is really, really super exciting. So we've got one presentation today and two esteemed discussants, but really before we get into that, we wanted to keep some time for hearing some really beautiful poetry and to really, again, start this webinar in a very human way. So we're going to hear from a wonderful poet who's also a youth activist and youth researcher who we've been working, from the Philippines. This has come out of a program with Plan International, and which has been looking at how to integrate pleasure into sexual health interventions, and it's been led by young people. And before Sophia from Plan International introduces the poem, I just wanted to read you one paragraph that summarizes what the project found, but written by the young people that led the research, because I think this really takes us to the critical matters that we're discussing today. So this is what the young people said. This project showed us that what made it special was its emphasis on pleasure, but not just as physical enjoyment, but as a right tied to safety, dignity, and self-worth. We learned that pleasure is not a luxury, it's a vital part of sexual and reproductive health. Talking to parents, LGBTQI youth, and community leaders helped us understand how deeply social norms shape people's views. Some were hesitant, others were surprisingly open, and many were simply curious. So this project and findings demonstrate that despite the challenges, this experience empowered us as youth leaders. We weren't just collecting data, we were opening doors to conversations that matter. And while we didn't wear lab coats, we did carry notebooks, courage, and a sense of humor. Research, it turns out, isn't just about facts, it's about people, and sometimes it's about laughing through the discomfort to find truth. And now I'm going to hand over to Sophia from Plan International, who's going to introduce the poem from Teresa. And sadly, Teresa's not able to be with us, and Sophia's going to explain why, and then we'll play the poem.
Thank you, Anne. It's lovely hearing to you, like reflecting on the words of the young people. Hi, everyone. I'm Sofia Novillo Funes. I work for the global team at Plan International. And before presenting Teresa, I would like to share with you a little about embracing pleasure. Embracing Pleasure is a planned international project implemented in Bolivia, the Philippines, and Zimbabwe between 2023 and 2024 in partnership with the Pleasure Project. It explores how to embed sex-positive, pleasure-inclusive approaches into SRHR programs, working alongside with youth advisors and local partners to amplify young people's perspective on sexual pleasure, well-being, and agency. The project generated practical lessons to inform evidence-based, youth-centered, and pleasure-inclusive SRHR programming across different country contexts and often restrictive contexts. In this embracing pleasure journey, fantastic things happened, and one was the creative ways in which the young people expressed their experiences and voices addressing these topics. And one of those young peoples is Teresa. Teresa is a 17-year-old girl. She's a peer educator from the Philippines, and she's dedicated to promoting sexual and reproductive health and rights and addressing online sexual abuse and exploitation of children. She's an active member of AGIP, that is a youth-led organization that champions SRHR, gender equality, youth rights, and environmental awareness in the Philippines. And she also participates in a youth radio program that empowers young people through media advocacy. She has a strong commitment on climate action, and her passion for social issues is further demonstrated through her participation in the Asia-Pacific Ministerial Conference on Disaster Risk Reduction, where she represented youth perspectives. Through various seminars and training sessions on social issues, she has strengthened her role as a youth leader. Unfortunately, Teresa nowadays isn't able to join us because currently in the area where she is based, a typhoon is happening, which has impacted the area with a massive power cut. But I really appreciate the efforts of our colleagues in the Philippines and, of course, Teresa, that had shared with us a recording of her reading this poem. So let's hear what Teresa has to say with her poetry that it's called A Journey of Dialogue, Rights, and Pleasure. Thank you, and over to you, Anne.
Good day, everyone. I am Teresa May Caragan from Philippines, a youth advisor and researcher under the Embracing Pleasure project. At this juncture, allow me to deliver the spoken poetry that I created, titled A Spoken Poetry on the Right to Pleasure, the Power of Dialogue. 1, 2, 3. Knock. A sound that echoes, soft yet insistent. A call, a question. Is there space for us here? To speak, to listen, and to understand. This is just not about a door. This is about opening hearts. This is katok, karapatan at kaligayahan, rights and joy. The essence of who we are. The privilege to feel, to embrace, and to live fully. In our communities, we ask, how do we talk about pleasure? How do we speak of happiness when we've been taught to hush, to shrink, to apologize for joy? But what if we learn to knock first? To seek permission not from others, but from within. To recognize that we have the right to experience life in its entirety, in all its messiness and beauty. So, we knock on the doors of families, of youth, of young mothers, and listen as they speak. Voices of teenagers, of elders, of those who have lived and loved, and those who have yet to understand the fullness of their power. We learn that the answers are not the same. Each person sees the world differently. Through the lens of their upbringing, their culture, their struggles, the home environment, the circles we keep shape the way we know and feel what is acceptable, what is taboo, what is ours to claim. But we also learn the question is not what we have been taught, but how we have been taught. How we have been taught to hide, to conceal, to suffer quietly, when pleasure is our right, when joy is not a luxury, but a necessity. Challenges come, of course. Not everyone answers the knock. Some are lost in language, in misunderstanding, in distance, in fear. Some doors are locked, but even locked doors can be opened. And so we persist. We listen harder, we knock louder. We give space for every voice, even the voices that hesitate. This is dialogue, this is communication. This is the bridge we build between hearts and minds, between what we've been taught and what we have yet to learn. Because we are all entitled to pleasure, to freedom, to happiness, and yes, to the right to decide what that pleasure looks like, what that joy feels like. So we knock again and again. We knock on the doors of silence. We knock on the doors of fear. We knock on the doors of the unspoken until they are open wide. And when they open, we will speak. We will listen. We will embrace. We will claim our rights to be, to live, to feel, and to celebrate. This is Katok, Karapatan at Kaligayahan, not just a project, but a movement, a revolution of voices, of bodies, of souls, a revolution that begins with a simple knock.
Thank you, Teresa, in your absence. That's a beautiful poem that Teresa, a young researcher working on a pleasure integrated sexual health program, wrote. And we really wanted her to be here and read it, but as Sophia said, very sadly, she had a massive power cut just before the webinar. But also it was really to remind us all of why we're here and really to humanize the subject of relationships, intimacy, love, pleasure, and why this research is really critically important. So without further ado, because I know that you have all come and we've got huge numbers of people registered for this webinar, you've all come to hear the news today, the research that has been published today on World Contraception Day that we have been working on for years, that the Pleasure Project has been looking forward to for even longer. And you're going to hear now from one of the co-authors who is going to run you through the research results, which are very striking. So Dr. Leanne Gonzalez is a scientist working on sexual health in WHO's Department for Advancing Life Course Health and Reproduction. And this includes the UN Special Program of Research Development and Research Training in Human Reproduction. And her research, normative policy and advocacy remit covers topics from sexual pleasure to menopause to LGBTQI plus health, which is a very large remit. But over to you, Leanne, to drop the research results and let everybody know what they've been waiting for.
Thank you, Anne. And I just want to confirm you can wave that you can see the slides that I've just shared. They were working before. Great. Thank you. Okay. Hi, everyone. Good morning, good afternoon, good evening from wherever in the world you're joining. My name is Leanne Gonzalez, and it is my privilege to be able to present these results to you on behalf of our full co-author group. This was a wonderful collaboration, as been mentioned previously, between the World Health Organization, HRP, the IBP Network, the Pleasure Project, led by a fantastic researcher out of the University of Oxford. And we will be talking about a systematic review and meta-analysis that is exploring contraception discontinuation due to sex life concerns. So I want to start off immediately with what the research question was, which is, what is the overall prevalence of and reasons for contraceptive discontinuation or switching pertaining to sex life concerns. And I want to break down this research question because I know we have a really lovely, broad set of people and expertise in this group. So we'll walk through each of these together. So when we talk about contraception for the purposes of this review, we were willing to accept any widely available contraceptive methods, regardless of whether or not they were hormonal, their mode of administration, or their efficacy. The one exception to that was male condoms. We excluded these because, to be honest, the question of do male condoms, are they real or perceived to have an influence on people's sex life, and does that affect their discontinuation? That's a pretty well answered and explained topic. And so we really wanted to focus on the other methods that don't get as much attention. Then we looked at something specific. We looked at contraceptive discontinuation and contraceptive switching. And folks who are coming out of the family planning universe or the SRHR universe will know these fairly well. But for those who don't, contraceptive discontinuation refers to when a user stops using a method. And they can do this for a variety of reasons. Someone may decide they want to become pregnant, or their method fails and they are pregnant, so they stop using the method. They may find it inconvenient to use. It could be expensive, difficult to access, a partner disapproves. And many also discontinue for health or side effect reasons. In our case, for this review, we were interested in a very specific type of discontinuation, what's called discontinuation while still in need. So we were interested in users who did not wish or plan to become pregnant, and yet stopped using their method. That was our interest. These were folks who wanted to keep using it, but the method wasn't working out for them, and so they just stop. We were also interested in contraceptive switching, which is, as the name implies, you start using a method for any one of the reasons I've described or more. It's not a good fit for you, and so you switch to something else, hoping it can meet your needs better. So that was what we were looking at from an outcome perspective, discontinuation or switching, because of how a method affects your sex life. And we said sex life concerns, but that is an incredibly broad topic. And we knew that if we were going to be screening articles, we were going to need to be more precise. We were very lucky to have this really lovely framework on sexual acceptability of contraception from the authors Higgins and Smith from, I think, almost 10 years ago now. And they present this really comprehensive framework of the various intersections and ways in which a method affects someone's sexuality, sex life, both as at the individual level as well as in their relational level and that dyadic interaction, and in a broader macro level. So we focused on individual and relationship factors, and that meant that we could account for everything from, at the individual level, changes in libido, things like vaginal dryness, pain during sex. At a relational level, we could also consider how someone might stop using a method because of how it is perceived to affect or actually affects their partner. For example, a male partner being able to feel the strings of an IUD during sex. The only thing that we excluded were sexual repercussions of seemingly non-sexual side effects. Those of you who are well familiar, either through use or through research of the different contraceptive methods, know that bleeding, for example, or pain can be some common side effects, as can, let's say, weight gain. Weight gain might cause someone to feel a little bit less certain or secure about their body image. Maybe it makes them a little more hesitant to have sex, and so they don't feel as confident, they discontinue. In theory, you could say that's a sex life concern, but we opted to be more conservative in our estimates. And so we said we would exclude things that were non-sexual side effects unless there was an explicit indication that it did affect someone's sex life. And so that was why they discontinued. So that's our research question. And then when you're doing a systematic review of the literature, I always describe it as kind of creating a fishing net and going fishing in the peer-reviewed literature. So you stitch together a net of keywords related to your research question, which you just saw, and then you throw it out across different databases to see everything that's been published in the peer-reviewed literature. You pull it back, and then, kind of like you do with throwing a fish back into the water or keeping it, you sort through things and see if you think that they're relevant to your research question or not. So in our case, the net that we threw out, we looked at 9 different databases over the last 20 years, from 2004 until the end of 2023, that not only captured 20 years of data, but also corresponds to 2004 was the year that the Reproductive Health Strategy was passed at the World Health Assembly, which for us was a nice way to mark countries coming together to make tangible commitments to reach internationally agreed upon sexual and reproductive health goals. We came up with almost 27,000 hits from our search. Once we deduplicated those, we had 16,660 unique articles, and we screened all of these at the title and abstract level for appropriate design, population, and context. That left us with close to 1,000 articles, 929, that were screened at the full text level. So probably about discontinuation or switching. And now we needed to drill down to see, do they talk about reasons? And then are they sex life related reasons? So that left us with 581. From 929, we were down to 581 that were articles that were not just about discontinuation or switching, but also had data in there as to why someone did that. And then we ultimately landed with 64 unique studies in the review. Now, that jump from 581 down to 64, I want to flag that we had 482 articles, 83% of studies of that 581 talked about reasons for discontinuation and switching, but did not mention sex life concerns either at all or in a way where we could pull out that data. So that in and of itself is already very telling about the extent to which even this literature is comfortable talking about sex, let's say. But we did find 64 unique studies, and that is huge. It's 42 quantitative, 22 qualitative, and that represents a total of over 125,000 participants, of which 52,705, a minimum of that amount, we can say confidently are people who discontinued while in need. So we're still very happy about the fact that we get to capture the experiences of such a large number of users. So I set up the research question, I set up how we did the search, and now let's talk about the results. We were able to do a meta-analysis of 25 studies representing 6,428 users who had discontinued their method while in need. And a meta-analysis is when you're able to take outcomes that are measured more or less in a similar way across studies and pool those results and come up with one meta result. So in this case, in pooling these similar studies across the 25, our overall estimated prevalence of discontinuation due to sex life reasons is estimated at 5%, with a 95% confidence interval of 3% to 8%. And so in short, we can say 1 in 20 users who discontinue their method while in need are doing so because of how it affects their sex life. Now, immediately, we want to probe this. We want to probe this answer and say, what else can we find out about this? I mean, you saw the massive number of users. We've talked about the variety of different methods. Can we get more precise? So we then opted to look at discontinuation due to sex life reasons, comparing hormonal versus non-hormonal methods. And again, there are more non-hormonal methods, but we are, of course, dealing with what's published in the literature. So on the non-hormonal side, we had 4 studies looking at almost 300 users, but only around one method, the copper IUD. While on the hormonal side, we were able to pull data from 18 studies, representing 5,433 users and a variety of different methods, which you can see there. And we found that hormonal discontinuation is at about 6%, and non-hormonal discontinuation is about 3%. But, and it's important to mention for those of you who are familiar with confidence intervals, those confidence intervals are overlapping. And indeed, when we do pairwise comparisons, we see that there are no significant differences between hormonal versus non-hormonal method discontinuation. So they're both hovering around that 5% mark. And the difference that we see between the two is not statistically significant. We went deeper at that point and we said, okay, let's see if we can break things out by specific method, because we had a whole bunch of hormonal methods grouped together. do we have the kinds of data where we can see, this would mean a study was measuring a specific method and we were also able to get data about discontinuation for sex life concerns related to that method specifically. Again, it narrows the studies that we can include, but as you can see, we were able to do this for the vaginal ring, the implant, the levonorgestrel intrauterine system, the pill, the injection, and the copper IUD. So what I will point out here, you can see the number of studies and number of users included. By far and away, you see again, we're hanging around this 5% mark. The exception to this is the vaginal ring, where you see it goes up to 16%. But the big flag around that is, of course, we've got just 2 studies with 19 users. So it's a very small sample size compared to what we see elsewhere, which is why the confidence intervals as well are also quite wide. And again, all the confidence intervals are overlapping. We did run pairwise comparisons of each method against the copper IUD as a reference. It was a non-hormonal method, and we opted to select that as our reference. And we found that there were no significant differences between the estimates for any of these methods individually against the copper IUD. And so what all that kind of tells us is that, no matter how we slice and dice this pie and split different methods, and I mean, separately, we looked at also specific reasons and found the same results. We're around this 5% figure, which means that we're pretty confident this is a robust estimate, this 1 in 20 number. The other thing that we did, I told you we meta-analyzed 25 studies. For the other studies that are included in the review, what we were able to do is do a narrative synthesis. And that allowed us to kind of look across the articles and try to summarize the key findings we were seeing across these to present them. There are several findings, more than I have time to present, that are in the article itself. But a couple of things I want to flag here. Are that one, switching was relatively overlooked. So I told you that this research question, we were interested in both discontinuation and switching, and then I promptly never talked about it again. And it's because only one article looked at switching exclusively, while an additional 3 considered both switching and discontinuation. So we didn't see as much data for switching. We also found that in general, reasons for discontinuation are rarely a central focus of a paper. If you think back to that 929 articles that we full text screened about switching and discontinuation, a good 300 plus of those talked about discontinuation and switching, but without ever talking about the reasons why. And of those 500 or so that do have reasons why, that's not to say that the article focused on that. Oftentimes we see reasons for discontinuation are, lost in a table 2, 3, or 4, or they show up in a supplementary table, or they're a secondary focus of a study. So we were surprised at how much we didn't see reasons for discontinuation or user satisfaction showing up more. Measurement for the reasons of discontinuation also varied. In many cases, people can only identify one reason for discontinuing. And so if we think of what it's like to be a contraceptive user, if you're a user of the pill and it's not working for you, why? Well, it might be because it's a pain to remember to try to take it at the same time, so it's inconvenient. Maybe you've noticed a little weight gain you're not happy with, and your libido has kind of dropped as well. If someone's asking you about these things, but they say pick one, which one of those are you going to pick? Chances are it's probably not going to be the sex life reasons one. Maybe you say it's inconvenient, but it's not a reflection of what the actual experience is like for you. There were other studies that did offer people the opportunity to select more than one reason. I would say they were in a far minority. We saw a lot of nicer data from the qualitative research where you could get more of that context. The other thing too is, however studies collected their data, they would often pool reasons, which for a systematic review and meta-analysis like ours is not very helpful. So, we would see reasons for discontinuations. They would break out percentages for, husband disapproved, accessibility was difficult, cost, and then they'd cover maybe like bleeding as one health reason, and then they would say other side effects, and maybe 30% would have discontinued for that reason, but there was no breakdown. And that's frustrating for us as researchers, because we want to know, if we're saying other side effects, that's things that are affecting people's lives. And so to see in some studies up to 30% of people just pushed together into health reasons, arguably we could be doing better. So I want to summarize by saying we're seeing 5%, and that 5% amount, that 1 in 20, that rivals other reasons. As I've said before, we don't look at discontinuation reasons enough in this space, but there is an analysis of 22 countries in sub-Saharan Africa that looked at discontinuation for adolescent parents and young women parents, young women ages 20 to 24. And they looked across about 10,000 young women parents across 22 countries, they found that, for example, discontinuing because of lack of access, 3.2% of the 10,000 participants said that they discontinued because access was difficult. Now, if you're in the contraception space, think about how much effort we place into addressing issues like access, into addressing issues like cost, where we see about the same. And yet we've got 5% for sex reasons, and we're not talking about it. The other thing I want to flag is that our estimate is likely conservative. This shows up in the discussion of our paper, and I invite you to read it. But for all the reasons I mentioned about how difficult this is to measure, and for the very conservative approach we took to making sure that every percentage point that's there, every participant where we're saying it's sex life reasons, we know it is sex life reasons. For example, when people say husband opposition was the reason they discontinued, their husband might be opposing it because they can feel the vaginal ring when you're having penetrative sex and they don't like that. But unless we could validate that, unless we knew that, we pushed out all of husband opposition, for example. So we took a really conservative approach, and that leads us to believe that, if we're in a world where there's better measurement, we could very easily see that that number is higher, and definitely higher when you consider both primary and secondary reasons for discontinuation. But we just don't have a way to measure that. But in short, I want to say we don't do enough to talk about users' reasons for stopping a method in ways that reflect their experience. So we can do better. And these are my final 2 slides. I want to talk briefly about implications for practice. So if you are providing contraception or family planning, counseling, and programming, you're providing those services, incorporate talks about sex and sexual acceptability when dealing with your clients or your patients. You can advise users about possible sex life related side effects. Hey, you're about to start the pill. Some people might notice it affects their sex life in certain ways. Maybe you've noticed a little bit of vaginal dryness. You can provide support and solutions to address known challenges. If you experience vaginal dryness, don't panic. That happens to some users. You can access lubricants in the pharmacy. I have some here. And then come back and talk to me if it's not working for you. And then ask questions and create an environment where questions can be asked. Check in with people. How is this affecting you? How is this contraceptive method working out for you? Do you want to find something that's a better fit? Creating that environment, I think, can go a long way towards making people feel comfortable with these conversations. On the researching side, we need better user-centered perspectives in measuring changes in contraception use. We need to be consistently asking users about their reasons for discontinuation with a comprehensive list of reasons, and we need to allow users to report more than one reason for discontinuation. I mean, we want people to be satisfied with their methods. We want people to be picking a method that works for their lifestyle, as complex as they are individually, in relation to their partner, and in how they sit in the world. We need better reporting standards once we collect this data well, so let's not pool different results. And we need more research into sex life concerns specifically. I will end by saying we had 64 studies in this review. We screened 16,000. Only 2 studies had discontinuation due to sex life concerns as their primary focus. So everything else we've been pulling through this review is through tables, it's through supplementary materials, etc. And we need to see that change. With that, I want to send a huge thank you to the co-authors, some of whom are on this call. And Anne, I'll hand it back over to you.
Thank you, Leanne, and thank you for walking us through the research so clearly and highlighting just what's so striking about how understudied the issue of sex lives is in a product that is for people to have sex. And so, and looking at such a lack of research in this area, and then also how conservative we were in what we classified as sex life concerns when that's rarely asked about, but yet still how significant this is over issues that have a far greater attention in the world of contraception funding, advocacy, and implementation. And With that, I'm going to hand over or ask our esteemed discussants to talk about what the implications are of this groundbreaking research for the world of contraception provision and use. And I'm going to start off by handing over to Dr. Samu Dube, who knows a huge amount about this as the head of FP 2030. And is really at the center of global policymaking and advocacy around contraception provision. Samu has over 20 years experience in healthcare, of delivery and financing, and her career spans a range of geographies, and also she's also been spent time delivering various models of healthcare across Africa. She came to FP 2030 from Afrocentric Health, where she led health policy and medical advisory work, but her experience in global health includes her role at ARC as head of healthcare investments, prior to which she was the Africa Program Director at PATH, leading the global campaign on vaginal microbicides. And she has a degree in medicine and surgery, a master's in public health, and also qualifications in tropical medicine, infectious diseases, business administration and finance. So a huge amount of experience, and I'm really looking forward to hearing your thoughts on what the implications are of this groundbreaking research. Over to you. Thank you.
Thank you so much, Anne, for this generous introduction. I don't know whether it has anything to do with sex and contraception, which is what we are about today. And again, congratulations to the team that has put together this lovely research. And I think it's telling at a time such as this, it's centering us to understand why we are doing this work, because after all, contraception is about sex. So happy Contraception Day, everyone, and I hope you're well where you are. As Anne has said, my name is Samu Dube, and I'm the Executive Director for FP 2030. So at FP 2030, this is a global partnership that is accelerating access to contraception globally, where we believe in a world where everyone can decide if and when they want to have children. At the core of that, it's about how they access contraception. So Anne and Leanne and the team that put together this particular study, I think you know very well that the conversations that we have had to date are often framed about what contraception and what contraceptive access would do for maternal mortality, for women to go to school, to finish their degrees, etc. But ultimately, at the core of why people use contraception is that they can have safe sex, they can prevent unintended pregnancy, and within that, at the core of it is about pleasure. And this is the missing piece, pleasure. I believe that sex, obviously, and all of us know, is not only about reproduction. As you know, it is about intimacy, it is about joy, it is about the essence of human connection. And if our advocacy and policy making is not about is about products, it's just about policies that ignore this essence of why people have sex, we risk designing solutions, we risk designing supply chains that don't really address the user's lived experience. You heard earlier from the lovely poem and from the lovely work that the authors actually have done. And I wanted to just applaud not only the curiosity that is also coming from WHO to lead this work, but the curiosity of the researchers to see what else is causing discontinuation across the globe. Research tells us that people often are more likely to use contraception consistently when it aligns with their desires for a satisfying sex life. Now, for too many, side effects that may include breakthrough bleeding, reduced libido, discomfort of anywhere. You heard that the authors were saying that they're being conservative in their approach. And we know that, so if we counter for all those issues, and then you put on top of that decreased pleasure, these are barriers to uptake and contribution. Today, we've got so many millions of women across the world who do not have access to contraception. And when messages such as, it will reduce my libido, it will reduce pleasure, go around in the community, it will further disalienate what we're trying to advance as a tool that is good for public good in communities. And this is actually not good for the progress that we are trying to make. Our global advocacy, therefore, must reflect this reality. FP 2030 currently is leading a campaign that is called Made Possible by Family Planning. So in this initiative, we're trying to raise new money for family planning, for contraception across the globe. We want to spark new momentum. Now, you can't spark new momentum when there are these negative issues that happen. Why? And we're not addressing them around reduction of pleasure. And we want to change the narrative around family planning. At the core of why we need to do this, we cannot ignore the issues and the discussion around pleasure. I believe that for the whole community, it's time that that narrative reflects what we already know to be true. And what we know to be true is that people are not just using contraception to prevent pregnancy. You don't take a pill or an IUD to just say, okay, I don't want to die. You take it so that you can have safe sex. Regardless of people's reasoning of taking contraception, it's important and it's valid everywhere in the world that we need to listen to those concerns. Contraception methods need to be tailored to meet the demand in people's lives, and discussions around contraception around the globe, and especially around family planning, the ability for one to decide, should not emphasize just health and economic benefits. Those are important. But what is also important is people's lived experiences on a day-to-day basis. We need to openly acknowledge that. We also need to shift our messaging that contraception is not just about preventing what you don't want. As you started, negative framing, right? You need to start with a positive framing. And I think this research actually sits squarely in that realm and arena of positive framing of contraception when it comes to pleasure, because it's about enabling the sex life that you want, and advocates need to normalize that discourse. And you and I have spoken before, and we talk about why priorities in research, priorities need to actually include pleasure when we're talking about contraception. And indeed, that sex is a key reason why people take contraception. And somebody reminded me yesterday that we should all remember that we as individuals are a product of pregnancy, which often is a product of sex. So let us not forget why we are doing research on contraception each and every day. So we need to ask users, we need to understand their lived experiences, and more importantly, we need not to ignore them. On the product side, we need to prioritize contraceptives that protect, empower, and enhance, not diminish sexual experiences. And maybe, Anne, I think if people would type, what is that product? What does that product look like? Where there is an intersection of you are preventing that unintended pregnancy, you are not going to diminish sexual pleasure, it is safe, it is easy to use, and perhaps it enhances sexual pleasure. I think I'll buy those shares of that product in a day. I believe that investing in research and innovation for methods that minimize negative sexual side effects, that feel better to use and that address both partner satisfaction is where we should be going as the research community and as the advocates community. If we are serious about universal access to sexual and reproductive health, that's where we should go. And so thank you so much for attending, and please keep the questions coming here so that we have this dialogue of an important issue. And women and ladies out there, go and demand sexual pleasure, demand your orgasm, demand the things that we are looking for when people are having sex everywhere in the world. Thank you, Anne, and over to you.
Thank you, Samu, and thank you. That's great framing, and also absolutely how much more enthusiasm would there be for safer sex and for contraception if contraception is framed positively, like many other products in the world. So thank you so much. I'm now going to hand over to our other really esteemed discussant, another discussant I'm really excited to hear from about the implications of this research, this new research. And Faisal is a pleasure enthusiast and also has many other qualifications and strings to his bow. He's an associate professor of clinical OBGYN. He's a sexual health and public health practitioner. He is also the director of an amazing program called the Women's Integrated Sexual Health Program in the Lebanon, which actually integrates pleasure into practice and delivery of services. But he's also president of the World Association of Sexual Health, the new president of the World Association of Sexual Health, who have been great supporters and champions of the importance of sexual pleasure in sexual health. But Faisal's also the chair of the Arab Women's Health Group and past president of the Federation of Arab Gynecology Obstetrician Society, and was also a past vice president of the International Federation of Gynecology and Obstetrics. I'll get my tongue around it. He's also a regular advisor to UNFPA and WHO. So many, many qualifications with which to speak about how this research should really land in the world now. So over to you, Faisal. Thank you.
Thank you very much. Thank you, my friend, for the invitation. And thanks to Leanne for the amazing presentation. And thanks for the audience for being here, everyone. Well, if there is anything, I was listening to the research, I really feel disappointed as a provider, as a gynecologist, because apparently we're not doing a good job. And this paper this research not only showed that only 5% will stop because of the sexual health, which is really bigger than the access issues and the cost issue. It shows that we're not doing a good job. We're not doing a good job. We are understanding the use of contraception, counseling, and advice in the wrong way. And that's really important. I mean, one thing is that this research is really gonna redesign and change the paradigm and shift the things that we providers of care are doing. Because for many people, they're thinking contraception is about prevention of the pregnancy. But it is at the same time, as you are advising and counseling people against unintended pregnancies, you are at the same time engaging or disengaging in a discussion that is way more important, because this is about safe, pleasurable sex and sex life. And it's about also saving lives, something we're missing. See, you've taken only one technical part in our attempt to counsel people to prevent unintended pregnancies. We are, without knowing or knowing, putting them at a higher risk of discontinuing the use of contraception or switching to something which is not probably very effective, thus exposing them to the risk of the pregnancy. And that lies the dilemma of really making that shift. Because if you continue doing this in the same conventional way before the data of this research, as I said before, we're not doing a good job. I see people in my practice desirous contraception, and only one question. I ask one question in relation to their sexual health and sexual life, and this shifts the whole consultation in the clinic. Then they start talking about how is this related to my desire, how this is affecting dryness, how this is going to contribute to my satisfaction and even to my pleasurable sexual activity, and so on and so forth. Only one question, because that one question will give the woman in the clinic and the young girl in the clinic the validation to really understand that you are really seeing the bigger picture. Because if you continue seeing only the unintended pregnancy, we're failing women and we're failing young women in so many levels. People might think 5% is not really much. See, 5% discontinuation rate. But it is that window of failure. It is that window through which the unintended pregnancies comes in, and then that is the contribution to the maternal morbidity and mortality because of unsafe abortion and so on and so forth. So it's not only about, counseling about the specific thing or not. It's about seeing the whole picture on this. The other thing also, talking about the services perspective, is that providers are not skilled enough or even trained enough back in the medical school or in the residency program about the importance of the comprehensive counseling around contraception, because they're not taught in the medical schools and in the curricula that contraception isn't only about unintended pregnancy. Contraception is a whole culture, it's a whole lifestyle, and it's a whole narrative about a satisfying and pleasurable sexual life. And that's why you have these zillions of options for contraception. Not only because commercially they want to sell all these different things, but because you have to be able to tailor and to cater and to make sure that every case you see, every counseling you're doing, you have the proper and the most suitable way of providing it and using it. Not only this, you're thinking of the young woman, but also you're thinking of the partner, you're thinking of the couple, and you're thinking of the whole thing. So providers will need a lot of work to change narrative, and that should be rooted back in the way they are taught the whole meaning and the intellectual meaning of contraception. And that brings me to the third point as an outcome of this beautiful research, is the importance of the health system and the narrative when you speak about policies and the programs, is to make that shift from, it's like when the oncologists see the cancer cases, they keep telling you about survivorship all the time. What women want, I'm talking as a gynecologist, as cancer survivors, they want quality of life. So you can't be talking about in the policies or the programs about prevention of pregnancy, and that's important. But we're going to talk about the quality of life with the contraception and the importance of having a quality sexual life with the contraception. And that makes the whole shift about programs to be inclusive, policies to be inclusive of the meaning of the sexual health, not only as a value or as a dimension of the overall health, but how to really integrate sexual health and sexual health meaning in the practice that we live every day. And that's the most important, because if that is not translated into the services, then we as providers are not doing a good job. But and like you're just now causing me a headache, because I have to think over and over again that we have to do a lot of work around this aspect of contraception at the service level. Thank you very much.
Thank you so much, Faisal. And also thank you so much for reminding us that this is about saving lives, and about the fact that what we've found is that considering sex lives, considering pleasure, considering desire makes our programs much, much more effective. The same with condom use as well. This is not an option that can be left out. This is not frivolous. This is absolutely critically important when it comes to saving lives and improving the way that we do our service delivery. I think also another important thing to remember is it's about changing the conversation. And as you say, a lot of that is about changing providers' attitudes to be able, and that's what we saw through the research. A lot of users really want to talk about this, but they're being not asked the questions, or they're feeling shy to say it, or it's being stigmatized. So I thank you so much for reminding us of that really critical point. I'm just going to finish off now. We've just got a couple of minutes, but just to say, it's, and if you all want to put your cameras on, that would be great. It's 30 years since the International Conference on Population and Development, where we really called for a humanizing of the delivery of contraception. And I hope it won't be another 30 years before we actually acknowledge why people use contraception. And just to remind us all that people have sex. And those of us working in sexual health have to really remember that people have sex. And guess what? Women have sex too, and women have sex often with men, and that's why they're using contraception. So I think really stopping avoiding this and stopping stigmatizing this will really help us throw off the shadow, the historical shadow we've got of fertility control, of the historical narratives of over-medicalizing contraception delivery, when very much this is about humanizing interventions and service delivery and really having this changed conversation. So I'm just going to finish off by saying that we've asked for 3 actions after our research. I've got 3 key actions for you all to take away with you in this large audience. The first one is make pleasure a priority in the global SRHR agenda. Remember that this is a really critical addition that will make your services much, much more effective. Remember that sex is a key reason for people using contraception, and good, safe sex is a great reason for using contraception. As we often say, it's a brilliant side effect of contraception, good, safe sex. And then also ask users if the methods affect their sex lives. Bring up that conversation, because when users are asked, as we saw in the research, it's absolutely a priority reason that they're stopping using contraception. So with that, I know we've just come to the hour. I just want to say a huge thank you to our amazing panelists and speakers who've really shared their fabulous expertise and their really heartfelt comments. I also want to say thank you to SRHM for all of the work they've done on the publishing of the article and the setting up of this whole webinar. And we've put in the chat the publication. We also want to say thank you to the funders for this work, from the Pleasure Project's perspective. That was the Vitol Foundation and the Case for Her. So thank you. And I think I'm just going to leave it there because we've just hit the hour. So thank you all so much for joining. And do read the research. Happy and pleasurable World Contraception Day.